Okay. So this poster is a summary of some of the work that I've been doing looking at uncovering the full scope of CPE transmission between hospital patients, which is missed by standard contact tracing investigations. Essentially, what we've done is introduce a novel contact network model to recover indirect transmission, which encompasses many missed pathways of disease transmission. So looking at outbreaks in hospital is often done with contact tracing like here, which tries to identify the outbreak structure and reveal transmission hotspots. However, a big problem with these investigations is that they rely on recorded physical contacts between infected patients. This inherently misses and falls down in the presence of missed contacts due to poor data quality or indirect transmission through things like hospital staff, visitors in the environment, which isn't captured in electronic data. So to mitigate these problems, what we did was introduce a novel contact model that borrows from semi-supervised graph learning to recover indirect contacts mediated by background hospital patient movement using a spatial temporal distance measure. Essentially then, this recovers links between patients who've had physical contact, but also those who have remained close or frequently came close during their hospital stay. The crux of this methodology being that the longer two patients coincide with the same infection in hospital, the greater the probability of transmission having occurred between them, be it that direct or indirect. So with our model, we tuned it and tested it on a distinct outbreak between 116 CPE infected patients, which for a large part had whole genome sequencing so that we could confirm and validate that our model was capturing routes of transmission. We found that our model well captured transmission and revealed a greater scope in outbreak structure. And then we proceeded to apply the same model and supervise to all CPE patients, which lack sequencing data to reveal plausible contacts between them, capturing a greater scope of transmission. So with our methodology, we were able to capture and predict the AMR gene presence amongst patients. For a label diffusion framework, we're predicting a patient's CPE genes using their close contacts. Given these different resistance genes are the fingerprints of outbreaks, we expect a high prediction accuracy when the distribution of resistance genes aligns with our model's contact network. And in fact, we do find this, and we find high accuracy when looking at a variety of different resistance genes. We also found that our model improved on traditional characteristics of outbreaks, be it in figure 4 over here, where we show our model's recovered contact networks compared to 3 others, with A being from a standard investigation, where only wards where patients came up as positive are considered an investigation, and B, a slightly improved methodology on this, where you look at the whole pathway of patients, but still missing this indirect source of interaction. We highlight as well the standard approach that outbreaks appear as completely disjoint clusters, which is completely not the case. Now, given our predicted performance and that our contact network model encompasses more patients, we conjecture that our model is the best characterization of disease transmission. Finally then, with our tuned and validated model, we applied it to an unsupervised data set of 860 CPE patients who had arrived in hospital initially as CPE negative and acquired it during the hospital stay. Our model finds contacts between 523 of these patients that have the same resistance mechanism, which is a weaker marker for transmission when whole genome sequencing isn't available. And this constitutes greater than half of all patients, suggesting a really significant burden of transmission from CPE across the trust. Moreover, then, we reveal significantly more linked and interconnected contact networks, suggesting that transmission is not isolated to clusters observable only in standard outbreak investigations. Now, given our model is trained, we can also apply it in real time to data like you would if you are deploying this model live, as we've shown here with separate time slots, where we're updating the contact network as more data becomes available, more patients enter the hospital, and there's a greater probability of those patients coming into contact and acquiring CPE from one another. So to close things off, what we've done here, we've highlighted the shortfalls of current outbreak investigations given their limited scope for capturing contact. And we've shown here ways to mitigate this by looking at indirect links mediated by background patient flows, which we've recovered with our model and then validated with whole genome sequencing. So if you have any questions, I'm happy to answer, but thank you for your attention.